Thank you.
Yeah,
Good
Dr.
morning,
Malik,
all.
you can start. Yeah.
Good morning, all. We welcome you, Dr. Prakash Marathe, and I welcome you to this special session of What's New in Ophthalmology, which was specially put together at the specific request of Dr. Partha. I'd just like to add that we will have all discussions, audience discussions, question answers at the end of all the talks, not in between, because it disturbs the flow of the talks. I would now request my co-chairperson, Dr. Prakash Marathe, to invite the first speaker.
Good morning. Good morning, all of you. I think it's a wonderful session in relation to ophthalmology. That is what's new. So many new things are there nowadays, and I think they are getting older within a very short period of time. Before that, I request the hall coordinators. Is there any timer which will be seen on the screen?
Yes, sir. It will start when the
Okay.
gives the presentation.
Now I invite the first speaker of this session, Dr. Rashmin Gandhi, and he has got the fantastic topic. Basically, artificial intelligence. Most of us hear about it in treatment of cortical visual impairment, and that is the relation of AI. I request Dr. Rashmin Gandhi to start his talk. Welcome, sir.
Thank you so much. Thank you. Good morning, everybody. I would like to first of all thank Dr. Prakash and
please clear it to 10 minutes, not 8 minutes. Timer.
And Professor Malik for inviting me for this wonderful session. And also a special thanks to Professor Sunaina Malik for giving me a topic which for which I really had to scratch a brain and prepare an absolutely brand new talk. So I have modified it a little bit. So because these are absolutely new topics. So just to give a background, what I learned as I accumulated this knowledge as to what is artificial intelligence, why it is being talked about so much, what is its role in a healthcare in general, where it has been used so far in eye care, and then we'll come to how it can be used or it's being used in cortical vision impairment. Because in CVI, the artificial intelligence is something which is evolving, and they are right now gathering a lot of data about how it can be made available to people. So let's dig in and see where we take this. So this is a headline of the New York Times around a decade ago. And this is from the game Jeopardy, where Ken and Brad, two of the participants, was defeated by a participant called Watson. The only difference, though, here was that Watson was not a person, but was a machine or what we call an AI. So an AI-driven machine defeated two seasoned players of Jeopardy, and that became a headline in New York Times a decade ago. This particular program of machine learning or artificial intelligence, as we call it now, was developed by IBM. IBM Watson was used for multiple, or is being used for multiple different facets of life. In healthcare, it made its entry with oncology, general oncology. It was, in fact, IBM Watson had that whole consortium had a tie-up with MD Anderson Oncology Hospital in Texas, and they tried using IBM Watson to first predict where a particular patient will go and what would be the best form of treatment, chemotherapy, radiotherapy, surgery, combination of all this. And it was fed a lot of data from all over the world. And it worked as far as science was concerned. It was giving a good amount of adjunct data to the physician, the treating physician and oncosurgeons as to how a particular, it was able to predict as to how a particular patient will behave 2 years from now, 3 years from now, 4 years from now. Of course, it didn't realize its potential because of the more of a logistic and a commercial angle. And last few years, it has been, now it is not being used in oncology, but it surely gave us an insight as to what a machine learning artificial intelligence can do in healthcare, how it can help us with the decision making and even designing a treatment plan. So why at all? Why we are looking at artificial intelligence and why we are not really relying on RI, what is known as RI or real intelligence? And there was a paper which we published in IJO in 2019. It was a commentary to a paper which was published earlier. And there we said that artificial, and the commentary was in response to use of AI in diabetic retinopathy. So the reason AI is being looked at is, especially in countries like India, where we may not have a trained health personnel in remote areas to look for, let's say, problems like diabetic retinopathy or glaucoma, the posterior segment evaluation, we not have the trained personnel on ground. And that's where there is an anticipation that that's where the second epidemic of lifestyle-related disease like diabetic retinopathy and glaucoma is going to hit. So how do we make sure that we screen, we take care of these patients early in the disease so that they remain healthy, and it also has an implication of reducing economic burden because of disability to the nation. So to solve this problem of access to healthcare in remote area, AI can be of great help. And as we saw in the case of IBM Watson, because of algorithmic approach, it can be used as an adjunct to diagnosis and prognostication of a complex diseases, because it is over a period of time when the data is fed, it probably can think ahead better than a human brain can do. At least that's what the anticipation is. That's the reason why AI is being looked at in eye care and healthcare. Now, how does it work? How does an artificial intelligence, how does it work? And again, we had worked on it. I had worked with scientists from IIT Madras when I was in Chennai in 2010-11, and we published this paper in one of the reputed engineering society journal in 2015. What we had done was we had worked on finding hemorrhages and then a neovascularization in patients with diabetic retinopathy. Can a machine tell us with reasonable accuracy about a presence of hemorrhage or presence of neovascularization looking at a fundus image? So what was done, how it works in most instances is that you feed a lot of normal data in thousands. So in this case, fundus images to the software. Software then learns as to what a normal looks like. And then it starts telling you that this is not normal, this is not normal. And then again, it is fed with the data which has, for example, in this case, neovascularization or hemorrhages. And then it learns to detect, first it learns to detect an abnormal red dots. Then it learns to differentiate between, let's say, microaneurysm, hemorrhage, and neovascularization. And all this happens because there is a constant input of data. It learns what you want it to learn. So initial period of artificial intelligence is completely driven by what you want the machine or that intelligence to learn. So you give the input of whatever data, and in this case, images. The machine keeps learning, saying what is new, what is normal, and how the deviation of normal can be represented in an image, and what is the deviation. And that's how it runs. And in the software which was designed by us at that time, had a reasonable accuracy of about 90% of detecting an abnormal fundal images, and a reasonable accuracy of even telling us that what that abnormality is. Of course, the whole idea at that time of this software was to say that can it be used as a screening device, and in the periphery, the software only has to tell us that this is an abnormal fundus and he requires a further examination by a specialist. So at least only limited number of people are then sent to specialists for further evaluation and treatment. The problem with many of these are, like, you may say that there is a 90%, 92% accuracy, but you don't want it to miss out. There should not be many false negatives, because even if it's 92% accurate, but if it misses out one pre-proliferative diabetic retinopathy, the whole idea is defeated, because then that person, because he was told that he's normal and does not have a problem, he might end up with a grave consequences. So that's the holy grail of the whole thing. Google, as we know, took up the same project a few years ago. They took images from Arvinda Hospital and Shankar Mitralaya. They developed a software reading fundus images, mainly concentrating on diabetic retinopathy, but their software, their artificial intelligence is capable of doing much more. They also reached the accuracy of 90% and more. They also deployed this AI for screening of large number of population in Thailand. And they also found the same thing, that it's false negative, the image quality, there still has to be somebody on ground to guide the eye as to what needs to be done. So that's about AI in healthcare. What about neuro-ophthalmology? Because CVI falls into pediatric ophthalmology and neuro-ophthalmology, where has it been used? And this is a beautiful study which was done by our friend Dan Milia from Singapore. So they studied, they fed over 15,500 images to the software. What was the purpose? They wanted the software to differentiate between normal and disc edema, and then they wanted to differentiate between a papilledema and a non-disc edema related abnormalities. And we found that 87.5% accuracy, 96.4% specificity, and to differentiate between normal image and any optic anomaly, accuracy was even higher at 92%. In this conference, in fact, yesterday in Rangachari's session, there was another paper on AI in neuro-ophthalmology, beautifully done from a group from Bombay, where they actually are using AI and another language called Wolfram language, and say that looking at the fundus image, can a software give you a further treatment algorithm and say that this patient is likely to end up in optic nerve fenestration and or a shunt procedure. And that's something which we are looking at. So with that background, AI in healthcare, AI in eye, and AI in neuro-ophthalmology, let's look at why AI in CVI is required. Because children, there are 19 million people who are visually disabled. Pediatric population require even more training for the screening, and there is a lack of accurate screening tools in the periphery. That's the reason why if AI can pick up the children with visual disability and also can tell.
Carry on, Rashmin, carry on, carry on.
So there are two projects that I want to talk about here in CVI. One is Project Track AI. Now this is being done by a startup called Dive Medical Startup. They are more looking at picking up children with a visual disability. And as we all know, somebody who is below the age of 4 or 5, pre-verbal children, it is extremely difficult to pick up these children who have a visual disability unless the patients are extremely observant or the visual impairment is bilateral and severe. So what does this Dive do? They have carefully designed stimuli on high resolution screen. So they present, and this is their patented software where they present a stimuli to even the small children, pre-verbal children. They use a gaze tracker to correlate between what the gaze tracker data tell you and how a child has responded to a stimuli. And this obviously initially will be done by a trained pediatric optometrist and pediatric ophthalmologist to say that to train the machine to pick up from the gaze tracker children with visual disability. Once the software is ready to say, okay, these are the children who don't seem to have a normal vision, they're not responding to the visual stimuli the way they should. And this pickup, how they pick up is by gaze tracker. And once the machine is ready with saying, okay, these are the people, these are the children who don't have a proper vision, then they will be escalated for a further examination by pediatric ophthalmologist. What about specific to CVI? Now, children with CVI have a peculiar problem with the vision. It's not only the loss of vision, they have visual deficit, which are more peculiar. Like they have much more difficulty in low contrast, as can be seen when you present the images to the normal children versus CVI children. They will miss if the image which is presented to them has a low contrast. Again, they can have a reasonable response to objects which are moving. So motion sensitivity can be spared, and they have intense difficulty if the environment in which they are moving in, either the image or the real environment, has a visually complex challenges. Then they are really lost. Now, this is the background under which the next model has used. This model, what it will do, again, they'll use a gaze tracking. They will determine the relative importance of features like background, faces, motion, contrast among children in facilitating children with CVI. Again, they'll use a gaze tracker in non-verbal children. They will train this with the help of gaze tracker. They will pick up saying, okay, these children are responding to this particular contrast level. These children are responding to the motion. These children are not responding at all. So basically, by screening these individuals, even you need not be a CVI specialist or a pediatric neuro-ophthalmologist or pediatric ophthalmologist, even a technician would be able to tell that this child has this amount of difficulty in CVI, and then depending upon that, they can be rehabilitated. Another interesting AI which I came across, this is a thesis from this doctor or optometrist, Dr. L. Fadii. And what they did specific to AI is that they, in fact, this has been already been published in one of the computational intelligence system journal.
Rashmin, I'm going to have to ask you to summarize.
So this is the last slide.
Okay.
So
fine.
what they have done is they have fed the visual field defect data into the AI, and they have now the machine has learned as to they have created a 3D avatar of a patient, and they have simulated what kind of difficulty a severe patient face when they navigate the surrounding, which may or may not be similar. And from that, now they hope to create an environment for that particular patient using this AI, because AI will tell you that he will be okay if you arrange a room in such a way, he'll not be okay if you arrange a room in such a way. And that then will be simulated in a real life. I again thank Professor Malik for inviting me and giving me this challenging topic. Thank you.
Thank you so much, Rashmin, for doing justice to this topic. I would now call upon my co-chairman, Dr. Prakash Marathe, for his talk on telemedicine, the new normal.
साइलेंट कर दीजिए मैडम. Hello.
Yes, sir, you're audible.
Okay.
Hey, we can't see your screen.
Just let
Go
me
again.
Yeah.
Share your screen again. Double click on it. Yeah.
Is my screen seen?
Yes. Make it full screen.
Am I audible? Yeah.
Yes. Make it full screen.
Yes, ma'am. Is it seen now?
Yes, Dr. Marathe.
Good morning, all of you. Thank you so much, All India Ophthalmological Society Scientific Committee, for giving me this opportunity to speak in this particular session and allowing me, along with Dr. Sunaina Malik, to conduct this session. I think in this era of COVID pandemic, most of us sitting at home, then we will not be able to move around. And there were so many restrictions in this COVID pandemic. And because of that, we have thought of so many options. And one of the options was telemedicine. Like you just can't sit at home and can't see your patients and advise your patients. So there were various platforms on social media, then internet, and you got connected with your patients. I think though physically you couldn't see your patients those days, I think this was the option available. And all of us took this particular challenge and tried to check our patients, treat our patients, talk to our patients, and give them satisfaction of treating also. And the same way our profession, that is ophthalmologist profession, general ophthalmologist, that was also continued. Even the fees were collected from all of us. And all this was on online platform. And this concept of telemedicine was there in the past, but I think it was not flourishing up. But because of COVID pandemic, most of us thought probably this is the greatest and best platform. And this became new normal. And when if this COVID pandemic will pass away in future, probably we'll be able to continue with this telemedicine in future also. I remember one medical legal case when one doctor gynecologist given the advice to the pregnant lady and the relatives on telephone. The concerned doctor was in the conference and he described that particular situation to the relatives, everything. And then he prescribed some drugs and afterwards there was some complication. The court blamed that doctor. Why have you misprescribed all those medicines on telephone? So that way it was not taken up in a good faith from court of law. So those days telemedicine was not that promoted by court. But in this COVID pandemic, even courts, government guidelines and rules and regulations, everybody allowed us for telemedicine. But one new concept you must remember and you should remember, that is disclaimer. Whenever it is the telemedicine prescribed, it is not equivalent to the physical examination and treatment. But then there are certain limitations. And for that, medico-legally, you shouldn't be challenged by the patients and relatives. So some disclaimer must be put from your side. This is not 100% foolproof. This treatment is not 100% foolproof because you have not seen the patient physically. So with this disclaimer, you should give telemedicine and online treatment. So online medical checkup and consultations have already started in this COVID era. That is in the first wave. It has been continued in the second wave. And God knows if the third wave comes. And I think in the first wave, we were sitting in the homes, even hospitals, but then patients were reluctant to visit your clinics and hospitals. But then this particular COVID era, that was the option. And take this opportunity to project and promote our practice. And then we shouldn't say that this is not the good thing in COVID pandemic, but accept this with some sort of positivity. With this telemedicine, you are saving on so many things. That is the physical infrastructure, what you have in your clinics and hospitals. But then you have to invest on so many things, like your internets, then your softwares, then medical legal aspects of those softwares, and whatever you are going to check to the patients, the documentation and notes and so many things. So whenever you are treating your patients by telemedicine and online consultation, most of the times you are casual. And that is the dangerous thing. So you shouldn't forget to keep your medical records. So medical record keeping is a must. It's a must. It's must. Don't forget that, because medical legal aspects, because of this teleconsultation, are also important. And this is again, though online, it is the consultation. And I always tell to my colleagues, don't forget to charge, because again, this is the professional conduct. One more important thing you shouldn't forget, that medical legal immunity has to be there. We are asking, because I am activist also, we are asking the government and their rules and regulations to be framed in such a way that whenever doctors are treating this patient in this COVID era, some sort of medical legal immunity has to be given to doctors and medical profession. You cannot say that because the physically patient is not seen, such and such treatment was given to the patient, and then there was some deficiency in that. So medical legal immunity has to be given to doctors and medical professionals by the government and court of law. Whenever you are examining the patients physically, if they are coming to you in your clinic, in your hospitals, I think protective gears, they are to be used. That is must for your direct consultations. And in this COVID pandemic, you must have heard, you must have read, you must have watched on television that government rules and regulations are there. Most of the times, they are changing every day. And you may not be knowing these rules and regulations while doing these online consultations and telemedicine. But then you must learn these rules and regulations regularly, because they are going to change your pattern of practice, your style of practice, the outcomes of your practice. So don't be reluctant about that. Make use of print and electronic media, television, social media. That way you can promote your telemedicine, because if you are sitting at your clinic, your hospital, or your home, maybe patients and relatives may not be knowing that you are available or not. So they should know that you are available for telemedicine and online consultations. So use of teleophthalmology. There are certain mobile apps, some companies. My previous speaker has talked about artificial intelligence. I think artificial intelligence is embedded in those scientific interpretations of those images, those diseases like diabetic retinopathy, and so many things. Without real intelligence, I think those can be very well explained by artificial intelligence, and that also should be promoted. Whenever you are working as general ophthalmologist or some specialty ophthalmology practice you have been doing, you must involve family physicians, super specialists, general ophthalmologists, that is your colleagues. Because suppose you are a general ophthalmologist and you have to interpret about diabetic retinopathy, the vitreoretinal specialist must be taken into confidence. Same way, cornea consultant, spine consultant, and so many super specialties in ophthalmology, because these are the related things in your practice and you must involve them. You must take this opportunity to promote your practice, to spread your practice, and horizons should be widened because of taking advantage of this telemedicine and online consultation. You can tackle the patient with all specialties which are available at and around. You must make use of optometrists, paramedics for taking fundus and other photographs and sending them to higher centers for interpretation. Suppose you are sitting at one place, your subordinates and optometrists and paramedics, they can take photographs from various places. And those can be sent to super specialty tertiary centers for interpretation. So you have to involve our super specialists for interpretation and further treatment. And I think with these words, I'm not going to take much more of your time. This telemedicine, which was not promoted in the past, though it was done by few of the surgeons, ophthalmologists, even government was trying to promote this teleophthalmology and this telemedicine business. And that time, that promotion was not that properly done. But now it is the need of the day, need of this COVID pandemic, that all of us must learn about telemedicine and teleophthalmology. I think this is a great opportunity for our profession. With these words, I'll try to save 1 minute of my presentation and I'll end here. Thank you. Thank you so much.
Thank you so much, Dr. Prakash, for saving 1 minute 20 seconds for us. And it was a very nice talk, because telemedicine is here to stay. I would now request you to please call upon our next speaker, Dr. Mritika Sen.
Yeah, I think I'll call upon the next speaker here. Latest trends in treatment of retinoblastoma. Dr. Mritika Sen, please. It's over to you.
Thank you, sir. I'll just start sharing my screen. Thank you very much, Dr. Malik and Dr. Marathe, for giving me this opportunity to present in this forum, and AIOS, of course. And I would like to thank my mentor, Dr. Santosh Runawar, for giving me this opportunity and for teaching me everything that I'll be presenting today. So I'll be talking about the latest trends and the recent advances in retinoblastoma and its management. Well, the management of retinoblastoma has undergone a dramatic change from a mortality rate of 98% to current survival of more than 98%. So it is one of the most gratifying cancers to treat. Now, like any other cancer, the primary goal here is to save the life of the child. This is followed by organ salvage and an attempt to save the function, which is vision here. So now classification of any disease is important to prognosticate the disease. And for this, we need, so we have the grouping as well as the staging. For grouping, we follow the international grouping of intraocular retinoblastoma. It is logical and simple and can be applied easily. And this basically predicts the eye salvage. Similarly, we have the International Retinoblastoma Staging System. This is important to determine life salvage. Now, till stage 3, the life salvage is excellent, more than 95%. But once the disease moves on to stage 4, the prognosis is quite poor, less than 4%. And this is where we should stop the transformation and detect it early and manage it better. So what is new in the classification? Well, we have, like the other cancers, the AJCC 8th edition. And here, retinoblastoma is the only cancer to have the addition of the age factor, which is the heritability. Okay, now coming to the management, we'll start with focal therapy. Focal therapy is used for smaller lesions. Basically, we have cryotherapy, laser photocoagulation, and TTT. TTT has, in fact, taken over the role of most of the things, including photocoagulation and cryotherapy. But what is new here is TTT plus or ICG-enhanced TTT. This is recommended for recurrences which are over scarred retina because it improves the uptake of the semiconductor diode laser. This is another such example where a macular tumor was treated effectively with ICG-enhanced TTT. Now, plaque brachytherapy is not new. It has been used specifically for failures following chemotherapy as well as recurrences. We have iodine as well as ruthenium plaque. But what has changed are the indications. We have the notch plaque, which is now available. We have the notch plaque, which is now available, and that is useful in treating juxtapapillary lesions without damage to the optic nerve. So this is one such example where a macular tumor regressed beautifully following plaque brachytherapy. Another example where the child had a stable mixed regression 3 years after plaque brachytherapy. Now, BARC has made from radioactive ruthenium waste the ruthenium plaque in India, and it is available in both the round as well as the notch form. And what is important is that the cost is less than 5% of the imported plaque, which dramatically improves the availability and accessibility. So focal therapy definitely optimizes vision. In the near future, what can we expect? Well, there is transscleral strontium radiation, and we have the chemoplaque. The chemoplaque is already under trial in Canada, and this is going to be basically a sustained release epibulbar topotecan device, which can be kept for 6 to 8 weeks. It's not really focal therapy, but it will be a sustained form of chemotherapy provided locally. Now, it is chemotherapy that has brought about a paradigm change in the outcome of retinoblastoma. In 1996, in the Archives of Ophthalmology, 4 landmark papers were published describing the role of chemoreduction in retinoblastoma. Now, what we follow here, this is the standard doses which have been shown here. We use 3 drugs, vincristine, etoposide, and carboplatin, every 3 to 4 weeks. Now, with chemotherapy, we are actually able to go back in time and shrink the tumor effectively so that focal therapy can be added to it. So this was another big tumor overlying the macula, but following chemotherapy, we have smaller scars which can be treated with focal therapy. Similarly, when we give chemotherapy, this is another example where this big tumor shrinks towards its blood supply and frees up the fovea as well as the optic disc, thereby improving the visual salvage. Now, this is not something new, but sometimes when we have a recurrence, even if it is this small, which can be easily treated with focal therapy, but look at its location, it's situated right over the fovea. Here, we reinitiated intravenous chemotherapy, not for 6 cycles, but just for 3 cycles. And here we have a very good regression with salvage of vision. So intravenous chemotherapy still remains the standard of care in developing countries, including India. But 25 years down the line from the time that those articles were published, today chemotherapy includes this entire spectrum. And beyond standard chemotherapy, we have high-dose chemotherapy, neoadjuvant and adjuvant chemotherapy. Now, intra-arterial chemotherapy is the standard of care in the West. This is here, the interventional neuroradiologist, he gets us access to the ophthalmic artery, and we are able to deliver the drug without the side effects of systemic chemotherapy. So what is new here is the 3-drug protocol with topotecan, melphalan, and carboplatin, and this allows fewer number of cycles and better outcome, plus we can reduce the dose of melphalan. So in our series, we had very good outcome, 100% eye salvage in group B and C, but this was similar to intravenous chemotherapy, where intra-arterial chemotherapy scores is in advanced retinoblastoma, group D and E. We had 92% eye salvage with group D and 54% in group E, which is definitely better than intravenous chemotherapy in such cases. So also intra-arterial can be used for residual tumors following intravenous chemotherapy and for recurrences with an eye salvage of 96%. Now, tandem intra-arterial chemotherapy, that is bilateral intra-arterial chemotherapy, is performed routinely in the West, but here also we are doing it. This was a case of a bilateral recurrence in a child which was treated with tandem intra-arterial chemotherapy. So IAC definitely makes a difference for group D and E and for larger recurrences. Now, coming to vitreous seeds, these still remain a challenge even after the advances in chemotherapy. So what is new here? Well, they're no longer just vitreous seeds, but we call them seeds in retinoblastoma. They include the classic vitreous seeds as well as the anterior segment ones, which include depository and infiltrative. But with OCT, we have been able to classify them further into prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds. So how do we treat these? Well, we have intravitreal chemotherapy. So intravitreal melphalan has been used extensively and still remains the drug of choice in the West. But in Indian eyes, we have seen that there's a lot of toxicity, including, you see here, the retinal pigment, epithelial atrophy, as well as uveitis and cataract. We have found that topotecan works equally well, if not better, with better bioavailability and fewer injections required. So the mean injections required are 3 as compared to 5 with melphalan, and it is much more gentle to the eye. So we use a 30 microgram regimen 3 weekly, unlike melphalan, which requires weekly injections. So it's much more comfortable for the patient. These are just some of the examples where whether it is vitreous cloud, spheres, or dust, they all respond well. However, there are still some seeds which remain refractory to this, and in which case we can give tandem intravitreal chemotherapy with the addition of melphalan, but at a lower dose. So this prevents the toxicity, but is quite effective. Earlier, we had reported a success rate of 100%. Currently, this is at 97% because we have expanded it to be used in more advanced cases. Additionally, intravitreal chemotherapy can be used for both infiltrative as well as depository anterior chamber seeds. For depository ones, we can use intracameral at a dose of 5 micrograms. Additionally, plaque brachytherapy can be added to it for the ciliary body tumors. Also, when we have diffuse and confluent subretinal seeds where the main tumor has regressed, intravitreal topotecan works very well and without the need for laser TTT, and so the retina can actually be preserved, thereby optimizing visual outcome. So probably at this stage, we can see that we have finally conquered the retinoblastoma seeds. Now, enucleation is still required for advanced cases. Of course, a long optic nerve is of paramount importance, but what is important is the after enucleation stage, because the pathology of the tumor is extremely important. Here we find that nearly 50% of the children, they have histopathological risk factors. Now, if we don't treat them, then this landmark study that was published earlier showed that we are actually sealing the fate of 24% of the children to metastasis and therefore death. But if we treat them with adjuvant therapy, this can be reduced to just 4%. Now, so it's important to remember that enucleation is not the end. If I can just take a few more seconds, I'll just complete it.
Please, go ahead.
So orbital retinoblastoma has a newer classification in these following types. Now, orbital retinoblastoma, in spite of exentration as well as EBRT, had very high mortality. But currently what we follow is multimodal treatment. So we begin with high-dose chemotherapy. After 3 to 6 cycles, we repeat the radio imaging, and if the extraocular component has resolved, we go ahead with enucleation. Usually the eye goes into phthisis and a safe surgery can be performed. But following this, we have to treat the child with adjuvant EBRT and complete the high-dose chemotherapy for 12 cycles. This has improved the survival to 90%. Of course, we do put in a primary implant. Even if EBRT is planned, we avoid an integrated implant but put in a non-integrated one. Custom ocular prosthesis is important to ensure the cosmesis for these patients. So even orbital RB now has a cure. And just to summarize, with all these treatment modalities, finally, life salvage has improved to 98%, eye salvage to 90%, and vision salvage to 90%. So just to conclude, retinoblastoma management is complex, but we have all the tools available with us. We just need to select the right one at the right time. These are all cost-effective ones, and we can mirror the salvage rates which are there in the West. So they definitely live and see. Thank you very much.
Thank you so much, Mithika. That was a very wonderful presentation and complete overview of retinoblastoma. And I think you have taken the trend of marking with a pen from your mentor, Dr. Santosh Onawar. I noticed that right away. Now, it is my great pleasure to invite our next speaker, Dr. Nishan, to speak on new developments in dry eye disease. Let me just briefly tell you how I hit upon Dr. Nishant. I don't know him at all, but I just heard him in a webinar. I'm forgetting whether it was a MOS webinar. I think it was a MOS webinar. And I liked his way of speaking so much that I decided that he has to be in this session. So over to you, Nishant.
Thank you so much for the wonderful introduction, madam. Thank you, madam. And thank you, Prakash, for having me here. So I'm going to talk a lot about dry eyes. Yes, we all know that there are a lot of new modalities in dry eye which are coming up, but we should never forget the olden days, what method we have been using, something which it has always been a standard protocol for so many years. So I'm just going to highlight something about the basic of dry eye and then let's more into the detail. So we all know the composition factors of the eyes, tears. You know, you have the lipid, aqueous, and the mucin, and the main hydrodynamic factors are the lid blinking and the closures. So there are two types of secretion which we should know, the basal and the reflex. Always we think about the amount of tears, but we should also know that the neurofactor also plays a major component for the tears to come. The functions of the tear film, we know that it is mainly used for the smooth optical surface. It keeps the surface very moist and it serves as a lubricant. It also transfers the oxygen which is required to the cornea. It prevents a lot of infection and debris. It washes away all the debris, and it's a pathway for the white blood cells in case of an injury. And it's a very perfect refractive media. We should know that the tears have a lot of characteristics. It's not only the amount of tears, but there's the pH, the surface tension, the refractive index, and even the tear evaporation time is also very important to know about the tears. Initially, they said that the dry eye is a disease of the ocular surface attributed to different disturbances of the natural function. But then Deuce later on rewrote it by saying that it's a multifactorial disease of the tears and ocular surface that results in the symptoms of discomfort, visual disturbance, and tear film instability. So it is not only the tears and the eyes one should look at when a patient comes with dry eye, but a lot of other factors as well. This is a simple slide, actually, when you know, it shows that it is not only the environmental factor, the lids, the blepharitis, but you have the core mechanism of the tear film instability, the hyperosmolality, the inflammatory markers, and goblet cells as well. I'll be telling about it later on in my talk. And the definition, we all know that it's mainly the aqueous deficiency and the evaporative, where we should concentrate a little more on the evaporative, where that is the main reason. And a little older age group patients, we always think about the Sjogren's and the non-Sjogren's diseases. Never to forget the drops. So I always ask my patients whether they are on any medications, because these also gives us the slightest hint and clue that they are on some long-term medicines which they have been using, which can also cause the dry eyes. There's a lot of symptoms which starts from burning, itching, sore, red, tired eyes, and not to say that some of them have even increased watering. So few of my patients still, when I tell them that they have dry eyes, even they say that they have watering. And then when you evaluate, there is a lots of loss in the lipid layer. And the signs, we have a lot of lid signs, which we should not forget. I also use a torchlight before I go into the slit lamp, because some of the main signs we tend to miss if we go directly into the slit lamp. So always start from the torchlight and then go on into the slit lamp and then start investigating the patient. So this is the thing which I actually follow in my OPD for all my patients, and I tell it to all the other doctors as well. Grade the severity, because it is very useful when the patient comes for the second time. We should know that whether their symptoms and signs have been increased or they have been decreased or they are being the same. So never to forget the lid. You have the cupping, you have the serous kind of discharge, you have lid margin keratinization, and then go on to the conjunctiva. Always make sure that you evert the lids. So this is one thing which we should not forget for any patient who comes with dry eyes, to evert the lid, upper lids, and also just pull down the lower lids. And never forget to stain. Sometimes a simple conjunctiva chalasis also can cause dry eyes and severe disturbances, and which will not be relieved with only tear substitutes. We need an excision as well. So coming over to the cornea, which is the most important factor, which is most affected by the dry eyes, try to find out the allergic history or any other detailed examination and history of the patient, irrespective of whatever age group they are. So this is the pattern which we have a slight understanding from the AAO guidelines, where after staining, you will know, you'll have a slight highlight of what is the main cause based on where the stain pattern has taken. Fluorescent clearance test is also one of the important factor where it is not, this is what main causes the reflex tearing. Because later on, when patients come with dry eye and they're not comfortable with only lubricants, we tend to put a punctal plug. But if they have a good reflex tearing, the first day onwards, they'll start complaining of watering. So which was dry eye will become a nightmare of severe watering. And there are other tests such as the tear film breakup test. So we grade it from 1 to 4 based on the seconds in which the tear film breaks up. And all the stains, that is the fluorescent, rose bengal, and lissamine, are important in each specific way. So this is the fluorescence test where you have all the other factors in the cornea, the micropunctate keratitis, and all the things which can be detected. There are other laboratory tests as well. That is the impression cytology, the tear protein assay, the quantitative mucus assay, and the tear mucin measurements. So this is a tear lobe osmolarity system, which actually make sure that you don't touch the conjunctiva or the lid margin. You should just try to touch the tear film height and increase tear film osmolarity of greater than 312, suggestive of a severe dry eye. This is another test called the Fern test, where you just have to take a sample of the tears and apply it on the slide and allow it to dry. You will find that there'll be a uniform arborization and the numerous branching which are seen. You can see in my first slide that is a normal eye, and D suggestive of severe dry eye, you don't have any branching, whereas B and C are associated with lack of lactoferrin and lysozymes in the tears. Inflammatory tests, you have the very spot test, which is used to test the MMP level, MMP9 level, and it's very simple. The same way, just retractor can just touch the tears. In 10 minutes, you will be able to get the results. A red and a blue will suggest of positive, a blue will be negative, and if there's no line, it is invalid. So what are the newer diagnostic modalities before we go into the treatment? The SPM is a device which actually gives us a lot of information on the infrometry, the tear meniscus, blepharitis, mammography, white-to-white measurements, and non-invasive beauty. These are all mainly for the tears. So I'll go with the infrometry. It shows the amount of lipids. So you can see that the picture on the left, you can see the colorful image which shows that the amount of lids is present. And on the right hand side, you can see it is a white layer. So that shows that the lipid level is very less in infrometry. And even you have the lipid layer analysis. Tear meniscus height, a simple way is done in a slit lamp examination by making a thin slit, but you also have these devices which will give you the height of the tear film. Non-invasive T-beauty time is also showing in these kinds of SBM devices. Mammography can actually be done for using our auto ref. If you try to sit in the auto ref and try to evert, you can actually see the meibomian glands as well. But these devices give a higher picture quality and helps us in treating more better. I follow the DEWS dry eye treatment plan according to which level the patients come under after taking the OSDI scoring. And yes, coming over to the management, we all know that there are so many types of tears which are available, so many types of drops which are with the preservatives, without preservatives, unims. But it is not only the tears, but why we are giving what tear substitute is what which matters the most. Because one, it should provide an adequate relief. It should increase the humidity of the ocular surface, and it should also cause a smooth ocular surface leading to an improved vision. Because if they are having some blurred vision, you should see whether it is a CMC, whether it is a HPMC, or it is a PVC, whatever it is, the patient, one is the comfort, and two, whether they are getting any relief. So and the dependency of the dose of drops also matters. It is not necessary that the patient should wear it for every 2 hourly. It is that we should make sure that they're comfortable with decreased dosage duration. Steroids is a double-edged sword. Yes, it helps in decreasing the inflammation, but it also causes some amount of dry eyes. Always make sure you give them with caution. Omega-3 fatty acids orally, yes, it does help in increasing a bit. Topical cyclosporin plays a major role. Autologous serum for severe dry eyes plays a role by, it definitely reduces the inflammation. And the preparation is simple, where you just take some blood and you give it, let it clot for 2 hours, and then centrifuge it, and then you can remove the serum and give it. So what are the other tear retention modalities? You have the punctal occlusion plugs, which are temporary or permanent. So you have the collagen or the silicone plugs which are there. And then you have permanent occlusion by the cautery, which you cauterize either the lower or upper or both based on the severity of the dry eye. Surgical modalities, yes, you have a lot of tarsography, amniotic membrane transplantation, and mucous membrane grafting for lid keratinization in severe cases. Other surgical modalities, what's new? In terms of treatment, we have this LiFi-Flow, which is an FDA approved. So this utilizes the vector thermal pulse technology. So it uses actually a kind of warm compression. So yeah, I'll just show you how it is done. Yeah. So it is actually, it occludes both the upper and lower device. It also causes a massage and it also causes some amount of heat as well. The other device which is used is the EI device. So this is something different from the LiPi-Flow, where it causes the intense regulatory pulse light therapy. So initially, when I showed you a slide where it is also the nerves which are helping in increasing the tears. Yes. So infrared nerve stimulation is also one of the factors where you can try to increase the production of tears and not only giving extra lubricant and making the patient comfortable. We should find the mechanism where which we are trying to help the patient to increase the tear film. So there are two types. One is the IRPL technology and the IPL technology. So each one has its beneficial factors, one over the other. But yes, after a treatment, so there is a treatment protocol, I think the first month, the third month, and the sixth month, you'll see that the lipid layer, which was broken, and you have a continuous layer. So the patients do feel comfortable symptomatically, which is one of the main treatment, and the efficacy is around 85%. So I'll just show one small video. So this is the EI. So this is my last video. So then they use some jelly so that it's a cold laser, but still it should not cause any burns to the pigmentation. So after they make sure that the device is charged. So yes, and you start clicking. So there are around 10 shots which is given on the inferior part, and then you can also sometimes give it on the superior part as well. So yeah, so this is the device, the EI device, which is used for the intense pulse treatment. Thank you so much, madam and sir, for giving me this opportunity. Thank you.
Thank you. Thank you, Dr. Nishant, for the wonderful presentation. I think it was really new, super new, and so many things you have covered in your talk.
Thank you,
people.
Prakash,
Thank
it's
you.
a pleasure
the audience
for me to
definitely
be
will
here,
be.
sir.
Yeah, definitely the audience will be benefited. Thank you so much.
Thank you, sir.
Now our next speaker. Before she speaks, I'll introduce a few things about that talk. I think both of us are presidents of Maharashtra Ophthalmological Society in the past. We have been working for Maharashtra Ophthalmological Society. Most of us are paying that professional indemnity insurance to the insurance companies. And I think the sum assured is a limited one. But under the name of Maharashtra Ophthalmological Society, we have started one project where all the ophthalmologists can be grouped together, and so that in the defined premium, I think that can be little less. The maximum amount of sum assured is decided by that insurance company. I think that benefit is passed to many more members of Maharashtra Ophthalmological Society, and particularly this particular movement will be benefited by other state societies and even at all India level. I invite my co-chairperson, Dr. Sunaina Malik ma'am, to present on MOS Professional Group Indemnity Insurance Scheme for ophthalmologists, that is MOS PGIIO. Over to you, madam.
Thank you so much, Dr. Prakash, for the nice introduction. And this scheme, as mentioned by Dr. Marathe, was thought up in my tenure as MOS president, another of my brainchilds. My brain works overtime most of the time. So we thought this would be good to have something for our members, something that I could do for our members, which would last a lifetime. This is the logo we devised, something like the FBS AI OS. And what is MOS PGIIO? It's a professional group indemnity insurance scheme for MOS members. This idea was sown into our heads by Foxy, who have an almost similar scheme, but ours is more cost effective and better. So the thought of doing something similar for MOS actually originated from my town, Aurangabad, and it took hold in my mind. So we came up with it. because I had always felt the need for some protection of this kind for MOS. And with the help of my colleague, Dr. A. Deshpande, it became a reality. What is professional indemnity insurance? It is to protect MOS members and to save them money, especially those members who are in solo practice need this kind of coverage very badly because they can be taken to the consumer court by any dissatisfied patient. They can be sued for a huge amount, and indemnity taken as a group is always beneficial because we know that united we stand and divided we fall. Under the new CPA Act, which has come into force since July 2020, a patient can sue the doctor for a sum of even rupees 1 crore or more. And now the case can be filed anywhere in the country, not necessarily in the city to which you belong. So the doctor would now have to run helter-skelter to attend the hearings, which would take a huge toll of him, both mentally and financially. So this becomes like a kind of chakravyuh, worrying about money makes the doctor's health, mental health worse, and poor mental health means managing money becomes harder. So to cut this chakravyuh, we thought we would come up with this. What are the benefits of indemnity insurance? The insurance company will pay the compensation amount ordered by the court up to the limit that you have taken. For example, 75 lakhs, 1 crore, whatever you have taken. The company will provide and pay for the advocate in the court. If you do not want the insurance company advocate, then a fixed amount will be paid by the company as advocate fees to your advocate. The rest you have to shell out from your pocket, depending on where the case is. For example, whether it is in the district or the state or the national commission. The same thing will be done if the case is appealed in the higher court. This coverage is for 1 year and the policy has to be renewed every year. Actually, we had decided that it would start from the day your premium amount got deposited with the company, but that didn't happen. So then it got started finally in February 2021, when the company compiled everything and put it together. The additional benefit of this was that we would get support from the company even in criminal cases. The indemnity insurance with 1-to-1 ratio up to 5 crore at a very competitive rate, but one has to enter the scheme before 31st December 2020. We relaxed this time limit a bit. So we increased it to 15 January 2021 so that more members could join. And finally, you will not believe that we were targeting 200 members. We ended up having 400 plus members entering this scheme. So what the company had suggested was that most of the members already had indemnity schemes going on. So they could do 25 lakhs in that current year and then increase up to 5 crores next year and think about discontinuing your existing policy when you shift your main policy to this scheme with retroactive date carry forward with same or more coverage. And in the beginning, 10% addition for each skilled or unskilled unnamed staff and 25 addition for refractive surgery was put in, which you could opt for. And the premium was with 18% GST added. So the few disadvantages which I found of this was that in case of a previous incident for which the case has been lodged, even after the date of deposition of your premium, it will not be covered by the company. And you cannot take the lawyer of your choice. Means you might just demand Ram Jethmalani, who is no more, or his son. So that would not be allowed. The difference between individual and group indemnity insurance is all the facilities given in both are the same. In individual insurance, the premium may be double or even more. And individual insurance is done by an individual directly. But in group insurance, it is done through a group of similar professional persons under a banner such as MOS. And the additional benefit we gave the MOS members was legal help from our legal committee, which was free of cost. This was the previous premium chart for individuals, which is no longer there now, because then they found those of us who joined in the first lot were given everything, means 10% loading, 25% loading for refractive surgery at the same rate. But for those who join now, this is the new pricing. And they have included 10% staff loading and 25% refractive surgery, whether you do refractive surgery or you don't, because it makes it easy for the company to put it in order. We formed a committee for MOS PGIO because we felt that since the office bearers change every year, we needed a committee to handle this smoothly. And the committee comprised of Chairman Dr. A. Deshpande, myself as co-chairperson, then Secretary Dr. Vardhaman Kankriya, all of us would remain for a period of 1 year. The President and Secretary current of MOS, these would change as the office bearers would change. Now, what was the procedure of taking indemnity insurance? You need to be a MOS member. There's a one-page form which I'll just show you once I finish the talk. So you had to download it, fill it up, sign it, and send it, scan it and send it. Right now, the digital signature is not available. So you have to do it offline. And you had to send an email to this email address, which we formed because we were finding it difficult to compile everything. And plus proof of transferring the premium amount directly in the account of insurance company, which is given in the next slide. And you would get the policy on email, not from courier. You had to download the policy. These are the company details. What is doubt one? If you have a previous indemnity policy, then what? In that case, your policy will act as additional security when the limit of group policy is over. The individual policy, when expires, you need not renew it. You can shift to this group policy because group policy is still protecting you. And if you want, your group policy can start working from the date of expiry of your individual policy. Doubt two, if you are in solo practice, then wiser to take a larger individual policy, I would suggest of 1 crore or above. What are the steps to be taken if you get a notice? Then just inform the committee of MOS PGIO and the company, forward the notice to them, and they will take care of the rest of the things. Thanks, and here's to a corona-free world. I hope we don't have a second wave coming up. I would, at this point, like to thank AIOS and Chairman Scientific Committee, Dr. Partha Biswas, for giving Dr. Marathe and me the chance to put this session together and giving us a chance to speak also. Thank you so much.
Thank you, ma'am. I think it was very well explained from your side about the scheme. And most of the members who are members of other states also will get motivated, and they may start such sort of scheme in their states also. And even the members of Maharashtra Ophthalmological Society, those who are not yet members of this particular scheme, will be motivated to become members of this. I think it was the wonderful presentation, self-explanatory, and all doubts were cleared from your side.
Thank you.
Best job done by you as chairman of this committee, ma'am.
The motive was that only, that maybe AIOS or other states could take this idea and amalgamate it in their societies. So I hope that happens because we are really benefiting. Thank you so much.
Thank you, ma'am. And I think with these words, I request you to invite the next speaker of our session.
Okay, I think our next speaker is none other than Dr. Maipal Sajdev. Has he joined us?
I don't see him.
No, I don't think. Okay, then we'll put his for later. We can take the next speaker, Dr. Ramesh Kekunia.
Yeah, he's there.
Okay, Ramesh. Ramesh needs no introduction. He is a stalwart in squint and pediatric ophthalmology. One of my favorite speakers and someone whom I really look up to. I wish I could do as good a job as he does in squint. But anyway, maybe I'll learn one of these days. Go to him and learn. So Ramesh, over to you.
Dr. Ramesh, please start your video. Audience will like to see you.
Ramesh, you can share your screen.
Yeah.
Can you see me? Yeah.
Yeah.
Thank you so much, Dr. Sunaina and Dr. Prakash Marathe, for this opportunity. I'm very happy to share my screen and talk about the patients with strabismus, what advances we have in the last maybe last year or last 1.5 years. That's what I'm trying to show here. Just give me a second. That is, I have reduced the presentation, I think. Just give me a second. It should be there.
I
In
saved
between-
another 1.5 minutes, so you
Yeah.
can take more time.
In between,
Will
I
be
invite
pleased.
our immediate past president, Dr. Mahipal Sachdev, who is here.
Okay.
Dr. Mahipal sir will be taking your talk after Dr. Amish.
Okay, sir. Thank you. Thank you.
Now I think it should be there, the
Yes,
slide.
yes.
Thanks
It is-
once
it is
again
visible.
to AOS to allow me to share some of the things which we have done. Some of the things I think I have learned from others in the past 1 or 1.5 years. In strabismus, I think one of the things is we all are worried about bleeding. I don't know this. Can you see the video? Yeah.
Yes, yes, it has started.
Yeah. So one of the thing is that we use this brimonidine eye drop. It's useful in strabismus surgery. It's useful in trabeculectomy, trabeculotomy, or pterygium surgery. You can see when I put this just before GA or topical anesthesia, the whole eye becomes white. This makes your strabismus surgery or any ocular surface surgery very much kind of bloodless, so that you don't have to. When you put it, immediately the vessels blanch. This makes whole of the surgery much more bloodless, which is an important thing in any of the ocular surface surgery for the immediate cosmesis or any kind of post-operative subconjunctival hemorrhage. It makes things very much easy. And we can also put this glue, tissue glue, to close the conjunctiva, so that we don't have to put this vicryl sutures. This reduces much inflammation also, and the next day patient does not have this poking sensation from this. So I would suggest any kind of ocular surface surgery, a drop of brimonidine is really good. Second thing is what we published last year. During COVID, a lot of namaste was going on. We used this surgery, this sign of namaste, so that how can it help in superior oblique tuck? Because all of us don't have a tuck available with us, tucker which is available with us. So we can use this namaste sign as one of the things.
We discuss the management of superior oblique palsy and demonstrate the procedure of superior oblique tuck. A 5-year-old boy presented to the outpatient department of our clinic with a complaint of left head tilt and outward deviation of right eye since birth. The best corrected visual acuity of the patient was 20/40 in both eyes. He had 20 prism diopter of right hypertropia, increasing to 30 prism diopter in left gaze and right head tilt. The right eye showed -3 superior oblique underaction and +4 inferior oblique overaction. Intraoperatively, Guyton's exaggerated traction test was performed with the help of Pierce Hoskins forceps, and superior oblique was found to be extremely lag. Hence, our plan was to perform inferior oblique weakening and superior oblique strengthening in the right eye. The superior oblique is approached through a superior-temporal incision. This is done to prevent post-operative scarring and to respect nasal intermuscular septum. The superior rectus muscle is hooked using a Helveston muscle hook. The fibers of the superior oblique are identified with the help of an iris repositor approximately 6 mm behind the temporal border of superior rectus muscle. The posterior most fibers of the superior oblique are identified and hooked. The laxity of superior oblique muscle in this case can be clearly seen. We suggest a simple and easy way to judge for the amount of superior oblique muscle to be tucked, a namaste sign. In India, we greet with both hands folded and say namaste. Similarly, both ends of the superior oblique can be folded on itself as much as it allows because of its laxity, and the amount of tuck can be performed where the lower ends meet. The namaste has to be full with both the lower part of the hands touching each other rather than a half namaste. A FIFO multifilament polyester suture is used to tie the lower ends of the folded superior oblique muscle. We use a fibrin glue to seal the conjunctival ends at the end of the operation. The 9-case composite picture shows good postoperative outcome for this child.
So that's one of the surgery what we can use for superior oblique. Another thing, Stacy and we had a workshop in American Academy of Pediatric Ophthalmology, where she presented this. When you do the superior oblique tuck, for the torsion effect, you need to tuck the anterior portion. So instead of taking the whole kind of muscle, we can also do an anterior superior oblique tuck. Some of the selective patients, you can use this procedure. And the last thing about superior oblique is in Brown syndrome. We can do what you can see in the picture as Z tenotomy. With the dot, 2 dot you can see, we can cut according to that. This is a superior oblique split lengthening procedure, can be used in Brown syndrome. This is also published in BJO. This is a very, very good technique. And the last one is for Brown syndrome. This is by Dr. Visa from Spain, which is available in WSPO's website as well. Instead of lengthening, we can do a shaving procedure of the superior oblique. What you are trying to see here is trying to shave and make it thin in terms of more or less, it's similar to Z tenotomy. You can see this fibers needs to be cut. The superior oblique has to be exposed till the trochlea. This is a very, very good technique rather than doing a tenotomy. We used to do tenotomy for Brown syndrome. This is a conservative superior oblique elongation as well as superior oblique lengthening procedure in terms of shaving is one of the methods we can use to treat the Brown syndrome. So that's about superior oblique. The other thing I wanted to touch upon is monocular elevation deficit. Rather than doing both muscle transposition, we can do single muscle transposition, either medial or lateral. Superior rectus, you can transpose this lateral rectus so that we don't have to do. Along with that, we can always perform inferior rectus. Instead of 2 muscles, we are doing just, instead of 3, we can do just 2 muscles. You can see the pre-operative and post-operative, the elevation improves. You can see this patient had also esotropia, the first patient with MED, both can be tackled at the same time. So medial rectus recession, inferior rectus recession, everything can be done with one sitting. This is the pre and post-operative picture of the same thing. Instead of doing 2 horizontal, we can do a monorectus transfer. That's the modification we need to do it. Corneal surgeons do a transplantation. I think even in muscles, we can do the extraocular muscle transplantation. Already, it's an autograft, it is not an allograft. If you see this video, which we published also in APOS journal, where you can do a routine resection. And once you do the resection, this portion, whatever portion, you can keep it and transpose it to the recessed muscle, what you are going to recess. This is the resection. The only thing is in a recess resect, we have to do the resection procedure early first, and then take a bit of the muscle. Either it can be 3 millimeter or 4 millimeter. I'll come to the dosage in a bit, and then transpose it to the transplant it to the medial rectus. Here I'm trying to do the disinsertion of the medial rectus. You can see in a bit muscle is disinserted. This is the piece I have taken from the lateral rectus. The distal end of it is sutured so that you can have a longer muscle and you can have a better outcome in terms of large angle strabismus like this. Large angle exotropia, post-transplant you can see here. Large angle esotropia, post-transplant. This is the outcome. And the last picture is a moderate angle 6-nerve paresis where we have done the transplantation. That works well. This is the dosage for these kind of surgeries where you can use. I have put 60 plus. We don't do it for a moderate angle or a small angle. We do it only for very large angle. Instead of doing 2 muscles, we do 1 muscle. This can also be done in recurrent or residual strabismus like this, where I am doing a lateral rectus re-resection with transplantation. You can see a residual exotropia in the top picture, which is corrected after 6 weeks with the transplantation. And also you can see, does it cause any adduction, abduction limitation? Not much it causes. This is the last thing I'm going to speak. Botulinum toxin can be used as a traction suture after when we do a recess resect for the transplant. We don't have to recess resect for the third no palsy. We don't have to place a traction suture. We can just inject botulinum toxin for these things. So I showed surgeries for superior oblique, that is namaste sign for superior oblique tuck. I showed sparingly anterior superior oblique tuck for some of the patients. Then I showed the two lengthening procedure, either a Z tenotomy with suturing or a superior oblique shaving procedure. I showed monorectus transposition for monocral elevation deficit. And I showed some unique indications for transplantation. And last thing, you can use botulinum toxin as a replacement for traction sutures in third no palsy. Thank you so much for this opportunity, AOS and particularly Dr. Sunaina, for inviting me for this. Thank you so much. I will answer any questions at the end of the session. Thank you so much.
Thank you so much, Ramesh. That was really innovative. And now I would like to call upon none other than our immediate past president of AIOS, Dr. Mahipal Sachdev. There's nobody who doesn't know him. He's so famous, and he's going to talk on his pet subject, plaques. So over to you, Dr. Mahipal.
So Dr. Mahipal sir is the immediate past president, and he's so fresh and so relaxed today. 2 days ago only he has faced his president.
Sorry to interrupt, sir.
Yes, sir.
Yeah, sir, last 10 minutes are left.
Yes, yes.
Actually, 8 minutes are left. If we can just...
Only one more talk is left. It's okay.
Thank you very much, Dr. Sunaina, Malik and Dr. Prakash. Pleasure being here. And I think I'm fresh because I'm in your session. So anyway, I'll be talking. I think the alarm bells have been rung before I started. So in any case, I'll be talking about femto laser assisted cataract surgery, which I am really feeling is the future of cataract surgery. And today, when we are looking at cataract surgery as a refractive cataract surgery, I think this is one technology that is taking us towards it. I'll just run through my slides because of I want to show videos more. So this is actually, I would say, a step towards perfecting the cataract surgery and making it more towards a refractive surgery. And the first and the foremost important is the capsular access. A trained surgeon would end up with a capsular access like this. And we all know that the capsular access has a profound effect on the effective lens position and the final emetropia that a person wants to reach. The second part in a femto laser is the breaking up of the cataract into small pieces, and it has been shown that there is a reduction in the EPT time or the total amount of energy that you are using. The incisions are obviously pretty good, and then you have the availability of LRI, which with the Donald-Field nomogram, you can actually try and correct astigmatism up to about a diopter. That's what I correct when I'm using an LRI. This is the catalyst system that I use. So the time that is taken, I will just skip this because you can do a capsulotomy, you can do sectioning, that is softening, segmentation. You can have 4 quadrants, 6 quadrants, 8 quadrants, and you can have these small, what is called as softening within these quadrants, so that you just need to aspirate it out. These are just various grades of cataract which have been shown, which have been cut with a femto laser, and the amount of energy that is being used is much less. I'll just show you a typical surgery. This is the, you have to capture the cone, and then you have to go into the lock position. This is the incisions, 1 incision, 2nd incision. You have the capsulotomy coming in. You have the nuclear disassembly that is going on, 4 quadrants with softening of the nucleus. And this is the time that is being shown as to how much time that is left. Now, after this nuclear softening has been done, we'll go on to the incisions. This is the nuclear softenings come from down up. You can see this is the primary incision that is being created. This is then the secondary incision that is being created. and then you will have the movement to the OR. This is the toric lens that is going to be implanted. So the mark is there. You can see it's a free floating capsulotomy, and you just have to hold the nucleus and you will be able to crack it and aspirate out the entire nuclear material. The pneumodissection helps separate out the nucleus from the epinucleus, and you can get a good separation that you can have and an easy aspiration. And then after the IA, the only difference in the IA is because when the laser is firing, it cleaves the cortex from the top. So you have to just go below the cortical, the capsular ring. So you can see this is the capsular margin, and then you can go ahead and place the intraocular lens, which you can see the lens being placed. This is a toric lens, and it goes and sits in the capsular bag there. The corneal incisions are, I think, one of the 4 things that the Femto does, but I would say the least important, and it gives the minimum leakage, etc. Now, this is a liquid optic interface where there is no hard talk onto the cornea. You can see that there is fluid that needs to be put into this patient interface. This is there is a second part of it which is put on the bottom of the machine, and this is where the suction is applied onto the eye, and then you get a 360-degree OCT. The OCT, as you can see here, is a 360-degree OCT. It will mark the anterior cornea, posterior cornea. It will show you the angle, and this will show you the anterior capsule and the posterior capsule, and then you can have this area where you are going to do the laser. This is the incision, the LRI that comes. This is the 3 triplanar incision that you can have. Now, the latest software, which is the COS6, gives you a direct entry of the preoperative data. The nomograms for Donald field for LRI are there. And there is also radial laser alignment marks. That means for toric IOLs, if like this is the cornea, you can mark on the alignment axis as to where the axis needs to be, and these marks are intrastromal, which you can see even in the post-operative period, and you can see whether the lens is in position or not. So this is the primary axis which it will show. This is the Donald field for the astigmatic correction that is there, and these are the ways that you can use this particular thing. And then these are the laser alignment marks that can be put on the cornea, which you can see on the table, as also you can see post-operatively. So you can hit the target for toric IOL in these particular cases. Also, there are studies now going on to do primary posterior laser capsulotomy with the Femto laser. Also, a Femto laser is being applied for the retina and even for ILM, etc., to make the ILM peeling much more easy in these particular cases. This is the laser incision, which you can see alignment with the marks that is there. So let us just now, in the 4-5 minutes that I have, I'll show you certain cases. This is a posterior polar cataract. The advantage in a posterior polar cataract is, I'll just go forward. When you get the OCT image in a posterior polar cataract, I'll just show you that the defect, I've just see this is the defect, a pre-existing defect in the posterior polar cataract. You can easily see the OCT will give you this posterior polar cataract, and then we will raise these bubbles so that we are leaving this area as a femto safe zone, and there will be this epinucleus cushion which will remain with you throughout. So this is what we can see. We are raising the fractionation of the nucleus, and we'll just show you that the disassembly is so very easy. I have not done any hydrodissection, I have not done any hydrodelineation, but the nuclear fragments can come out very easily, and you can see that there was a posterior capsular defect, but that was preserved right till the end. So in posterior polar cataracts, you have great outcomes. Now you look at a hard cataract, you can see we have done, this is a black cataract, and mind you, until of course the cataract is white, it will help in, you can see these bubbles coming, and you can see the easy transaction. This is there in this black cataract. So the laser is able to crack the nucleus and reduce the amount of energy that is required. So just to show you that hard cataracts is another area where we have the excellent advantage of femto laser, which is there. This is a subluxated cataract that you can see. In the subluxation, you can see on the OCT, this is vitreous blob here, the iris going down, and there is a subluxation which is there. So the important thing is that even though there is vitreous, you will be able to make the pupilloplasty, make the capsulotomy wherever it is, and you can see that this is a great capsulotomy that we get and a nuclear separation that is there. We are having the posterior approach to take away the vitreous that was coming in. And you can see that the capsulotomy and the nuclear fracturation which has happened after putting the endocapsular ring, the entire lens moves on towards the side, covers the vitreous, and you can go ahead and remove the cataract in a very good way. So a posterior polar I have shown you hard cataract, I have shown you subluxated cataracts where the outcomes are much better when you're using a femto laser. This is the post-op position that is there. So friends, I think there are several other places where you can use it when you are having a phacomorphic or a white cataract. The intumescence does not allow you to have an Argentinian flag sign because we are doing the capsulotomy in a closed chamber technique, and in this closed chamber technique, there is no Argentinian flag sign or runoff. Because even if the fluid comes out, it may leave some postage stamp perforation. So you use trypan blue and you will get good capsular access in almost more than 95 to 98% of these cases. So to sum up, there is room for improvement in the logistics. The machine could become more small. It could have it could be a mobile device, and the click fee that we have to pay today obviously has gone down significantly from the 28,000-30,000 that we were paying. And if it goes down further, we can use it. If we can use it even for multiple eyes, that is there. Posterior capsulotomy, if it comes, is good. Future laser technologies are also being worked where refractive enhancements and treatment of the implantable IOL. That means within the IOL, the femto can be used to change its refractive index. And also you have laser-induced refractive index change where femto is put in the periphery of the lens. So that the presbyopia can be taken off, and this is the compaction of collagen fibers that can be done without the refractive surgery, and presbyopia correction could be possible. So femto, I think, would be a buzzword that we will be listening over the next couple of years, and I'm sure as the prices go down, the click fee goes down, it will become a gold standard for cataract surgery. We are using the femto also in refractive surgery, and there is going to be widespread use for that. So so as the technology of femto cataract is evolving and it is finding widespread use, not just in the simple cases, but in complex cases, I think it is time to take the leap of faith and switch over to the power of femto. Thank you very much for the time.
I'll just request all the speakers of this session to please be on video mode. I want to take one picture of all of us. Thank you. Please come on the video. Yes, just for remembrance sake. Thank you. I don't think we have time for questions. We just have 18 seconds left. One quick question in telemedicine.
Sorry to interrupt, ma'am, but that's really not possible. I'm really sorry, ma'am.
Okay, no problem. That's all right.
Thank you everybody for the wonderful session. I think everybody enjoyed it. Even speakers.
Thank you, madam.
Thank you everyone for such an informative session. By this, we conclude this